Today I'm going to discuss population-based assessment of breast reconstruction, care patterns, disparities, and outcomes. So we'll go over the clinical background for why this is relevant, discuss a paper that we did on patterns of care, a paper we did on disparities by insurance status, and then, a paper we're working on disparities by insurance status, and then a paper that we've just finished and are submitting on complications and outcomes. So I just wanted to start with this simple picture. This is a picture of a woman who had a mastectomy. And so, why would you want to do breast reconstruction? So, well, this woman, if she's going, so the physiologic purpose, obviously, for the breast is lactation. So you could reconstruct a breast, but you're not going to resume that normal physiologic function of the breast. But beyond that, this woman, she can't go to Penny's and buy a bra anymore. The clothing fit is an issue. There's often body image issues associated with this, partner issues. And so this can have a meaningful impact on quality of life for patients. Not uniformly. Some patients are like, I'm fine, one less breast. But for many people, it can be a big deal and bigger than they might anticipate. And I was just talking with one of my patients last week who's a physician herself, and she had bilateral mastectomies, and she's like, I'm struggling with this a lot more than I had anticipated. And so this is a real clinically relevant phenomenon. And so breast reconstruction exists to try to restore the damage that was caused by trying to treat cancer and doing a mastectomy. So interestingly, despite the fact that this is not necessarily good for one's quality of life, mastectomy rates themselves are increasing. And so this is data from the Mayo Clinic, and it showed that for a while the percent of their patients having mastectomy was going down, then all of a sudden it started going up again. And the causes of this are probably multifactorial, but nonetheless this has also been reproduced in SEER data. You see the same trend, although it shifted a little bit later than the Mayo Clinic data. And so the reasons for this could be due to some patients preferring just to have a more definitive or radical procedure, some people feeling like keeping their breast is a bit of a ticking time bomb. There's sort of an interesting gestalt amongst physicians that a lot of this is patient-driven, and that there's sort of like some interesting sociocultural things going on where women are like, take them off. I just want them off. But this is an interesting finding, and potentially part of the reason mastectomy rates are increasing is because availability of breast reconstruction itself might also be increasing. And so women might be like, well, let's try again. So I wanted to, with that background in mind, discuss some of the different types of reconstruction. And I stole all these figures from the MD Anderson website, so a couple are a little blurry, but I figured it was better for me to take from my own institution. So this is an explanation of implant-based reconstruction. So a woman has a mastectomy, and then there's a tissue expander, which is a fluid-filled balloon, essentially, that's placed under the pectoralis major. Here you can see it in cross-section. It can be inflated percutaneously. And so you do a mastectomy at the same time you put in this tissue expander, and then over the course of a few weeks to a few months, you inflate it, let the skin expand, and then you do a final surgery where you swap out the tissue expander for a permanent breast implant. And depending on the type of mastectomy that's done, sometimes you can just put in an implant at the get-go and get everything done just in one single procedure. But either way, implant at the outset or a tissue expander followed by an implant, this is called implant reconstruction. Another type of reconstruction, there's a sort of a broad category called autologous reconstruction, and that just means you take tissue from one part of the body and move it somewhere else. And so this is a picture of an autologous reconstruction where tissue is harvested from the abdomen, and they take the blood supply, they cut it down here, and then they attach it in up here on the internal mammary vessels and use that to reconstruct a breast. As you can imagine, this is a lot more involved than an implant-based reconstruction. It has certain benefits because there are certain women walking around Texas today who have a little bit more tissue here than they would like. And so some of them are happy to put it to good use somewhere else in their body. But it's a longer recovery time, about 5 days in the hospital, and a couple of weeks of a pretty hardcore recovery after that. And then another option, which is a bit of a hybrid, is, and oops, I forgot the didn't fix that, sorry. So there's a latissimus reconstruction, and this is where some skin and muscle are taken from the back, and they're wrapped around, and they're used to reconstruct the breast mound here. And oftentimes that'll be supplemented by using a smaller implant as well. So this is using autologous tissue plus an implant. And this is a little bit quicker recovery time period, but then you lose the function of the latissimus muscle, and so if you're trying to push yourself up from this position, that becomes impossible. After the reconstruction of the breast mound itself, then there's nipple reconstruction, and this is just a picture of one surgical approach to nipple reconstruction from the MD Anderson website and some pictures of what it looks like at the end of the day. They also tattoo the areola. The timing of reconstruction is also an issue, and radiation comes into play with this as well. And so you can do a mastectomy with immediate breast reconstruction, or you can do a mastectomy, let the woman heal, do their radiation, and then do a delayed breast reconstruction about 6 months after the fact, or even like a year or two after the fact. There's really no threshold for when you can do delayed reconstruction. And so then this plays into how you design studies to look at reconstruction and its complications and patterns of care. And radiation itself becomes problematic in trying to integrate what we do, which causes all sorts of havoc for the plastic surgeon with what they're doing. As one of my friends who's a plastic surgeon said yesterday, we're the straw man for them, so they can blame all their complications on us. So if you start to think about this not as a clinician, but as a health services researcher, there's a number of unique aspects of breast reconstruction that present challenges in trying to study this from a health services research perspective. So for starters, it's a very long process. You might not finish your reconstruction until 1.5 years after you were diagnosed with breast cancer, or even longer. And so you need to monitor and follow these patients' claims for some time. The patients most likely to get breast reconstruction are the patients who are most likely not to be eligible for Medicare. So this is much more frequently a younger woman quality of life issue than an older woman. And so SEER Medicare or TCR Medicare isn't really going to be the best data set to use to study this. There's multiple types of reconstruction. There's a gazillion codes for reconstruction, and you have to sort of parse out the different types. And come up with reasonable categories. The timing is an issue because some people have it up front, some people have it delayed, and how do you design your studies, particularly looking at outcomes relative to what index date do you choose, the date of mastectomy, the date of reconstruction, etc. Also, this can be with or without radiation, so how do you adjust for that, and how do you look at the impact of radiation on reconstructive outcomes? There are no randomized trials to show you what's the best type of reconstruction, what will make patients the happiest in the long term. And that's kind of good for a health services researcher because the level of evidence we can provide isn't much worse than what's already out there in the literature. So that kind of helps us a little bit. And going along with that, all the published data are generally from centers of excellence. There's little patient-reported outcome data, and so it's not particularly good quality. And another challenge that we ran into is that sometimes a procedure or a diagnosis that might be a complication might also just be billed to justify further care. So like it's common to have some need for revisions after an implant-based reconstruction, and so they might code it as a complication, but really there was a plan for a need for a revision all along, and so it's not really a complication, but it might be coded as such. And so that can create confusion. That's why it took us 1 year to do this project. So I just published this editorial in the JCO last week, and so I'm just going to read this. So because breast reconstruction is inherently complex, is expensive, and does not influence classic cancer outcomes such as recurrence or survival, it may not be routinely available to patients in healthcare settings where scarce resources force rationing of care. Therefore, availability of breast reconstruction is an interesting marker of quality, one that may indicate a well-resourced medical system that can afford not simply to cure cancer, but also to intervene to repair the physical and psychological damage done by cancer treatment. So this is an interesting quality indicator. It's different than like giving chemotherapy to a node-positive breast cancer patient where you know it's like could be a matter of life and death. This has nothing to do with survival. It's all about trying to optimize the quality of life experience for our patients. And I could just say anecdotally, so I finished practicing at the U.S. Air Force Base in March of 2010. and I stepped into practice at MD Anderson in May of 2010. Enormous difference. I couldn't pay to get a plastic surgeon to see my patients in the military, unless if you were like working for the commander, somehow miraculously you got a plastic surgeon right away. But my average patient, they would never see a plastic surgeon. They'd have their mastectomy, they'd have their radiation, and then maybe if we were lucky, like 6 or 12 months down the road, we might send them to plastic surgery and they might be seen. And at MD Anderson, it's very common for plastic surgeons to be involved in patients' care from the very beginning, and for an integrated team to try to approach the patient and determine what would be the best reconstructive plan to integrate with the rest of their cancer treatment. So I'm first going to talk about this Patterns of Care study, which we recently published in JCO. The first author is Reshma Jagsi, who is an awesome collaborator and radiation oncologist at the University of Michigan. And she was actually the one who approached me a couple years ago wanting to try to study this with claims-based data. So a lot of the credit for this work goes to her. We put together a cohort using the market scan data, and the market scan data is a convenient sample of claims coming from about 45 large employers covered by 100 plus payers, and then also in 2002 they added data from small and medium-sized firms. So it's a little opaque exactly where the data is coming from, and it's not necessarily geographically representative, but there are patients from throughout the country who are included in this data set. So I first just want to go over how we created this cohort, and I apologize, this looked a lot better on my monitor than it does on this slide. But we first used the market, so the market scan cohort, we purchased just patients with some diagnosis code for cancer, but it was any cancer, and this was Dr. Giordano's data. And so just using this giant cohort, we selected out women who had a mastectomy between 1998 and 2007, and so we identified about 45,000 women. And then because we really wanted to look at this whole window of time period where patients might get reconstruction, we decided to require that patients have continuous coverage from 3 months before their mastectomy through 23 months after mastectomy, so we get about a 2-year window. And so unfortunately you lose a ton of patients in the market scan data when you apply such a stringent inclusion criteria. But we felt this was important so that we could really understand the use of both immediate and delayed reconstruction. We excluded patients with distant metastasis because reconstruction is not typically used. And we excluded patients who got radiation before their mastectomy because that's a very unusual situation and that might indicate something particularly strange with their cancer. And then we required that patients have 2 or more diagnosis codes for breast cancer or DCIS from 3 months before through 12 months after mastectomy. So in total, we ended up with about 20,500 women. So as you might expect, age was strongly correlated with receipt of reconstruction. So women under 40 had over a 70% likelihood of reconstruction, and women in 60 and over had about 35% likelihood of reconstruction. And then also, as I would have expected, the use of reconstruction increased by year. And it's interesting to note that legislation was passed at this point in time that required health insurers to pay for breast reconstruction. So part of what we might be seeing is an impact of that legislation. So in 1998, the use was about 45%, and by 2007, it had gone up to 62%. It's not a huge increase, but definitely an increase. If we look at reconstruction and other treatments and the trends over time, so this is the data that I just showed you as far as use of reconstruction, but just graphed as a line instead of bar graphed. And then the other thing that we found was interesting and has been reported by other groups is this steady rise in the use of bilateral mastectomy over time. So women are showing up and saying, I want them both off. Interestingly, a decrease in the use of radiation, which is a little bit unexpected because the evidence supporting radiation in node-positive breast cancer has actually been improving and strengthening over time. So my hypothesis is that the decrease in radiation probably reflects the fact that more women without an indication for radiation were choosing to have mastectomy over lumpectomy and radiation. But since we don't have tumor staging information, we can't be sure that that's what's going on. And then relatively stable use of lymph node surgery. And then we also looked at the trend in the types of reconstruction. And so interestingly, back in 1998, autologous was definitely the most common type of reconstruction, but then this slowly decreased over time. And instead, implant-based reconstruction was increasing. And then autologous plus implant, which could have been like these lat flat patients, that was also increasing. This was tissue expander only. So these are women who had a tissue expander placed but never finished their reconstruction. And then autologous plus implant also increasing. So in general, a decrease in the use of autologous and increase in the non-autologous approaches. We also looked at geographic variation in use of reconstruction. Sorry, this doesn't show up quite as well as it did on my computer screen. And I thought this was interesting. So, you know, in the area where the traffic is the worst in the country, so the I-95 corridor is where the highest use of reconstruction was. And then Colorado stands out, and the whole South and the Midwest kind of stand out as one block, and then the West is a different block. So I think potentially the demand for reconstruction could at least be in part explained by regional variation in local cultures and their preferences for breast reconstruction. DC actually had the highest rate of breast reconstruction, it was about 80%, but they had a very small N. And then North Dakota had the lowest rate. I think it was like 19%. So we created a simple multivariate logistic regression model to look at predictors of receipt of reconstruction. So some of the interesting things that showed up in our model was the number of the density of plastic surgeons at the state level. We couldn't get it any more granular than that. And we got this data from the American Plastic Surgery Society. I forget what their precise name is. But in any event, it looked like if you got to a threshold of 3 per 100,000, there was a significant increase in the odds of reconstruction. Other things that were interesting was that county level income quartile was strongly predictive in a dose-dependent manner. So the more wealthier patients are definitely getting more reconstruction than the poorer patients. Bilateral mastectomy was strongly correlated with receipt of reconstruction. So generally the choice to have bilateral mastectomy for patients is going hand in hand with the choice to have reconstruction as part of their care. Lymph node surgery, women with lymph node surgery were less likely to get reconstruction, and so this is probably a marker for patients with invasive breast cancer as opposed to DCIS. And then women who got radiation were much less likely to receive reconstruction. And so this is a surrogate for more advanced disease, and also radiation in and of itself makes reconstruction more complex and challenging for the patient and physicians alike. So obviously this seems to be associated with a barrier to receiving reconstruction. So to summarize this paper, we found that reconstruction rates were increasing significantly. The profile of women receiving reconstruction is that they're younger, they're having bilateral mastectomies, they have earlier stage disease, and that there are some structural and systematic predictors of this, that women with higher SES, women who live in states with a lot of plastic surgeons, are more likely to receive reconstruction. I didn't show this data, but we found that the type of insurance, whether or not you had a capitated plan or an HMO versus a PPO, was not predictive of receipt of reconstruction. But interestingly, if you had an HMO or a capitated plan, this was predictive of a higher likelihood of having delayed reconstruction and a higher likelihood of having implant-based reconstruction. So these are probably the simpler and less demanding forms of reconstruction and require less coordination from physicians. So we thought it was interesting and not terribly surprising that a cost-conscious insurer might steer patients more toward this route. But in general, this is a success story for American healthcare, that we are able to provide, and we're able to increase our ability to provide for patients access to breast reconstruction, which does have proven psychosocial benefits in patients who desire it. So things got interesting because as our paper was under review, I was asked to review a paper from Toronto that was reporting the population-based experience with breast reconstruction in Canada. And that paper, I think, was just published in JCO as well. And if you just read that paper at first blush, you'll see that breast reconstruction rates were increasing in Canada as well, although the overall rate was not as high as it was in the United States. But if you try to do an apples-to-apples comparison and you just pick out the patients from Ontario who had invasive breast cancer, and they were only looking at immediate breast reconstruction, and then you pull out our published immediate reconstruction rates, so it's pretty striking. So the striking things are that the use of immediate reconstruction for invasive breast cancer in the United States is much higher than it is in Canada. And also, over this time period that we studied, it's really started to go up, whereas in Canada, it remained flat through 2011. So this was interesting, and I was asked to write an editorial on this. And so in investigating this further, it's interesting to note that in Ontario, they only have about 1 plastic surgeon per 100,000 residents, whereas in the US, the average is about 2.2. So we have about twice as many plastic surgeons per population as they have in Canada. And in our analysis, we found you really needed 3 or more to sort of have optimal or the highest reconstruction rates, and so Canada is way lagging on that. And interestingly, you can also just go onto the Ontario Health website, and they publish their delay times for reconstruction. And so their target is that if you decide you want to have breast reconstruction, that 90% of patients should have it done within 6 months. And so Ontario can't meet that benchmark that they've set for themselves. So their current wait time is up to about like 280 days. So they seem to be under-resourced to meet the demand for breast reconstruction.
I wonder if there's any information about the people from Canada who come to the United States. I mean, are they not getting the services there, so they're doing medical tourism and coming here to get their reconstruction?
I think that would probably be a very small segment of the population because it's darn expensive to pay for your reconstruction yourself. So I bet that happens occasionally, but I doubt it would be that common. So this was my editorial. And so as I reflected on this is what I wanted to write, but they didn't let me because they thought it was too inflammatory. But collectively, these findings depict a system that is under-resourced and thus unable to consistently provide immediate breast reconstruction for invasive breast cancer, while the provision of universal government-funded health care promises a tantalizing solution to the problems afflicting cancer care in the U.S., the functional result in Canada appears to be a system that uses attrition as a means of rationing care that could be considered elective. In the Affordable Care Act, the U.S. has chosen a different direction, seeking to expand private insurance and Medicaid to facilitate coverage of most Americans. As these changes take effect, it will be vitally important to monitor their influence on cancer care. Within this context, use of immediate breast reconstruction is likely to be an important bellwether, signaling the extent to which the healthcare system maintains the full complement of resources needed to not just cure cancer, but also repair the damage caused by treatment. So this is the perfect lead-in to my next topic, which is disparities in use of reconstruction, and how does insurance status influence receipt of immediate reconstruction. So with the Affordable Care Act taking effect, and with part of the plan being that patients who are underserved would be sort of shunted off to Medicaid and increase Medicaid enrollment, it's interesting to ask the question, how does use of immediate breast reconstruction differ as to whether or not you have private insurance or Medicaid? And so this is a project we started recently, and we wanted to examine use of immediate breast reconstruction in the market scan cohort compared to the Texas Medicaid cohort. And so this is what we're doing. And we do have cohorts, so I'm going to show you some real data, but we need to get all the right numbers. So I moved around the sequences so that it will work well for the manuscript. So if we start with women with breast cancer diagnosed in 2000 to 2007 in Texas, we have about 16,000 patients in the TCR Medicaid data. And I'm not sure how many we'll have when we just look at mastectomies, or look at women with a diagnosis code of breast cancer who lived in Texas in the market scan data. But we'll figure that out. And then we'll limit it to women ages 18 to 64. And then we'll select from Medicaid those who had a claim for mastectomy performed within 12 months of diagnosis. And then in market scan, we'll just pick out those women who had a mastectomy. We'll exclude women with distant metastatic disease. And we'll include only patients here with microscopically confirmed breast cancer, or patients here who have 2 or more diagnosis codes within a time interval surrounding the mastectomy. And then this will give us about 1,360 patients from the TCR Medicaid data to work with, and 2,700 patients from market scan. So the idea that I had to circumvent the major limitations of the Medicaid data is that rather than imposing some sort of arbitrary restrictions that patients had to have continuous coverage for so long, that we would just look at the data that we have and we would just select patients who have a claim for a mastectomy. And then we would look on that same day to see if they also have a claim for reconstruction. So this way we don't have to exclude 99% of our cohort because they didn't have continuous coverage, because all we really care about is one day. So I think this is a reasonable, not terribly flawed approach to get something useful out of this Medicaid data.
So when did the state law come in that breast cancer women got Medicaid coverage?
I don't know.
Because that, going backwards is still going to be a problem, but going forward should be less of a problem with breast cancer and Medicaid than it should be for Medicaid and just about anything else.
Yeah, you would think so, although I don't know what year that took effect. I think Linda's data that she presented at the last meeting still didn't look particularly glowing for breast cancer because you have to renew every 6 months, so I think there are a lot of gaps. But I don't know when that law took effect.
Well, another way of doing it in something like this is just to make an assumption that if they weren't on Medicaid, they didn't get it, and that's another sensitivity sort of analysis you can do, because you can then look out 6 months.
Mm-hmm. Sure. Yeah, that's probably true. But yeah, so we could do that. So for now, what the data I'll show is just looking at immediate reconstruction on the same date as mastectomy. If we compare these two cohorts, so this is just using the claims that we have, which we know are going to be incomplete. And if we use the claims we have plus the tumor registry data, only about 12% of patients are recorded as receiving radiation. I think that's too low. And this uses the registry data too, right, Jing? Yeah. Whereas if we just use the claims from MarketScan, we get 27%. The chemotherapy numbers are closer, and this is solely based on claims. So I thought this was a little bit reassuring that we were at least in the same ballpark. And then lymph node surgery was identical, which is a nice positive control because this is happening on the same day as mastectomy as well. And so we're obviously capturing that with a high, have to be capturing the vast majority of lymph node surgeries since we're at 92%.
You don't look like you're losing a lot of people on the chemo.
Yeah. So we're capturing some, I think, meaningful information. I don't think it's perfect, but it's not terrible. And so this is what we found as far as receipt of immediate reconstruction. So in the Medicaid population, 16% of them had immediate reconstruction, and in the MarketScan population, just over 50%. So a really big difference. Obviously, we are not adjusting for stage since we don't have stage in MarketScan, but there is a meaningful difference here. So what we're doing right now is we're trying to code various socio-demographic covariates and then use that to create a multivariate model, which I'm sure will show that having private insurance results in a much higher likelihood of receiving immediate reconstruction. And then I'd like to do a sensitivity analysis where we just pull out those early stage Medicaid patients, since we should have staging information for many of them. Those would be the patients who would be most appropriate and eligible for breast reconstruction. And then maybe we'll find that 20% of them are receiving reconstruction, which will still be substantially lower than the MarketScan patients. And I think then we can conclude that it's not simply this vast disparity in stages that's driving this observed association. So finally, to talk a little bit about complications and outcomes. So this was a challenging project. And we went through multiple iterations of trying to assess this. And what we ultimately decided to do was to take our original MarketScan cohort and then to select out 3 relatively pure groups. So one group having mastectomy with no reconstruction within 2 years, that's about 9,000 patients. Another group with mastectomy with immediate implant reconstruction, and this could either be like they put in an implant on day 1 or they put in a tissue expander first, but then they had that swapped out for an implant within 2 years. And that was about 3,000 patients. And then patients who had immediate autologous reconstruction, about 2,600. And so we asked the question, how do complications vary with regard to reconstructive technique, and how does radiation modify these risks? So the outcomes that we chose were rehospitalization within 30 days of the index mastectomy, a wound complication, and we just used diagnosis codes for wound complications, an infectious complication, also with diagnosis codes. In women who underwent implant reconstruction, the likelihood that they had the implant removed, so that's a failure. So if you have an implant put in that's supposed to be your new breast and it has to be taken out, that's a problem. And then fat necrosis in the autologous group, and so that's refers to some of the fat cells dying, and that typically will cause a lump that you can feel in the reconstructed breast that may be tender, symptomatic, or painful, and sometimes it's asymptomatic and you don't do anything about it. So if we just simply graph complications by type of reconstruction, so if we look at rehospitalization within 30 days, it was higher in women who had autologous reconstruction than women who had mastectomy alone or with an implant, but not super high, 4.4%. And this is not surprising because an autologous reconstruction is a much bigger surgical procedure. If we look at wound complications, the number increases. 9.5% in the autologous group, 4.5% in the implant group, and 2% in the mastectomy alone group. And then infectious complications were relatively common, 20%, and it didn't matter what type of reconstruction you had. So this was simple. We then created multivariate models for these outcomes. And so when we adjust for other patient factors, it still was the case that autologous reconstruction was associated with higher odds of rehospitalization. These other factors were not. As far as wound complication, we see a dose gradient with autologous having the highest risk. These other factors not predictive. And then as far as infections, similar risk with implant or autologous, and radiation was also a risk factor for infection, which is kind of interesting because radiation's not, like infection is not on our consent forms. So it's not classically thought of as a key side effect from breast radiotherapy. So then we are interested in, so these are binary outcomes looking at this happening at any time in the 2 years after index mastectomy. But one of the questions we are interested in as radiation oncologists is that we get blamed for all these complications that occur. And so which ones are really our fault? And so how do we assess the impact of radiation when we have an outcome that's really spread out over time, and some of it's happening before radiation and other after, and also the timing of radiation is different for each patient. And so the solution we came up with for doing this was to, for each month, define the outcome variable. So like in month 1, did you have a wound infection? Yes, no. In month 2, did you have a wound infection? Yes, no. And so on and so forth through month 24. And then use a generalized estimating equation to adjust for age, receipt of chemotherapy, bilateral mastectomy, and year of diagnosis to model this outcome for each month. And to determine the association of radiation with this outcome spread over time. And because there's sort of in general 2 intervals, the pre-radiation and the post-radiation interval, we chose a priori based on the average start date for radiation to look at 1 to 6 months and then 7 to 24 months as separate models. So thanks to Jing for working on this and struggling with it. So if you look at rehospitalization after mastectomy without reconstruction, this is the percent of patients who are rehospitalized for each month. And this is the months since diagnosis, i.e. mastectomy. And so, for example, this would be the first 30 days after mastectomy. And in this time window, patients who did not receive radiation had about a 2.7% risk, and patients who did receive radiation had similar risks. But here's in blue is the yes radiation curve, and in red is the no radiation curve. So in unadjusted analysis, patients who received radiation had a higher risk of rehospitalization in this early time window. But in the adjusted analysis, that p-value is no longer significant. And the p-value for the later time window is also not significant. And I should mention that this line is the median time from mastectomy to start of radiation, and that these lines are the interquartile range. So the majority of patients are starting their radiation in this time window. So if we look at rehospitalization after implant-based reconstruction, really no difference by radiation. If we look at rehospitalization after autologous reconstruction, there was a little bit higher risk of rehospitalization in those patients who were going to receive radiation, although this risk predates even starting radiation. So it's hard to assume causality there, but there is an association. And then, interestingly, after radiation, patients who had received radiation in this time window were more likely to be hospitalized than patients who had never received radiation. If we look at infections, this p-value was significant, but that's a really small difference. This is in patients who had mastectomy without reconstruction. After implant-based reconstruction, it's interesting. So in this early window, there's really no difference based on whether or not you receive radiation, but then there's this late spike of infections that are occurring in the patients who receive radiation. And whether these are de novo infections or infections associated with a procedure, we haven't drilled down to that level of granularity, but it's interesting to see that presumably the radiation, which is happening in here, is exerting a late effect on the tissue sensitivity to infection. Justin, I'm sure you'd believe that radiation can increase the likelihood of infection. So,
Yeah.
as a spine surgeon, we're probably your nemesis. So we probably do get appropriately blamed for those complications. And then after autologous reconstruction, you see the same general pattern. So it's interesting. If you look at wound complications, first with mastectomy alone, very small likelihood of complications and really no clinically meaningful difference. Same after wound complications after implant-based reconstruction, and pretty much the same after autologous reconstruction. And then if we look at implant removal in the patients who had implant reconstruction, so in the early time window, really no difference, but then in the late time window, the patients who had had radiation were more likely to lose their implants. And this is totally true. So we do not like to radiate implants for this very reason. And the absolute effect was not that huge, but it was statistically significant. And the overall numbers, as I recall, in women who'd had implant reconstruction, if they didn't get radiation, still about a quarter of those patients lost their implant. And if they did receive radiation, like 28, 29% of those women had their implant removed.
Have you submitted this yet?
Not yet. It's written.
I mean, do you also do it in terms of a cumulative rather than?
Yeah.
I mean, when you say these are small, yeah, but you're doing it month by month.
Yeah. So
1% a month for
right.
a couple of years.
Yeah. So we report the total risks as well.
Yeah, I mean, but just a cumulative graph might be nice.
Oh, a cumulative graph. That's a nice idea. Yeah, thanks. That's a good point. We can think about that. I like that idea. Thanks. So to summarize, rehospitalization and wound complications are highest with autologous reconstruction. Infections are common with either reconstructive procedure, and radiation modestly increases certain complications, particularly infection and implant removal. Oh, I think I skipped over the fat necrosis. So the plastic surgeons love to blame us for this. But you can see there's not a trivial risk of fat necrosis in the non-radiated patients, but there was still a little bit of an increase in the radiated patients. So our next steps are to, a lot of these patients can either choose, they can have a mastectomy or they can have a lumpectomy with breast radiation. So our next steps are to look at the utilization patterns of these two different approaches to early breast cancer, and to compare the complication profile using a similar framework of these two approaches, and then also to compare the cost, because a lot of these reconstructions require multiple trips back to the OR, and so looking at the cumulative cost of patients who've had a mastectomy with reconstruction and no radiation compared to women who've had a lumpectomy and radiation, I think is worthwhile to inform our understanding of the relative value of these two treatments. So I have a great group. Jing did all the analyses for all of these projects. Thank you, Jing. And then Reshma at University of Michigan is awesome. And Sharon provided all the market scan data to us. And then we have some clinical collaborators at Michigan and MD Anderson. That's all I have. Sorry, I didn't have any good jokes in this talk. I couldn't come up with anything funny to say about this topic. So.
I have just one question. I've done a little bit of reading on integrative cancer care. I don't know if they do it at MD Anderson, but I'm just curious, with the integrative cancer care, they really push healthy diet, exercise, stress and there's supposedly a better outcomes in those that don't. Have you thought about looking at complication rates in the centers that do that versus those that don't?
Yeah, it's kind of hard to pull out which centers do that type of have those sort of structured interventions and which don't. So it's not something that I'm sure we'll be able to tease out from claims. At MD Anderson, we actually have a prospective randomized trial ongoing right now for women who don't eat well and don't exercise and were diagnosed with sort of a bad breast cancer. They're randomized to either standard care or a very intensive lifestyle modification intervention. And it will be interesting to look in that randomized trial to see who got reconstruction and was the side effect burden different or complication profile different for those randomized to the intervention versus the control group. It's an interesting idea.
Thank you.
Thanks.